Okay, here is 2016 Radiology from the next step. This is our Advanced Coding, Chapter 3. Starts out talking a little bit about your positions in your placement, just kind of a review. Component coding, we've talked about this before, your professional, your technical, and your global. Very good information. A little bit about what contrast you can include or code extra for and what you can't. Starting with case 3.1, this is a chest x-ray. Follow-up for a placement of a hemodialysis catheter. So that is the diagnosis code you use. First, regardless of what might be found on this chest x-ray, it was ordered for placement confirmation. So that is the diagnosis code that you use. It will be a Z code. I think they do have a little bit of stuff here or potential diagnoses there. That's not going to be too pertinent for us. Again, this is a follow-up chest x-ray exclusively for to check the placement of that hemodialysis catheter. 3.2, this is again for a line placement. They do go on, the clinical symptoms here is congestive heart failure, and they're checking the placement of that central venous catheter. They do talk about the central venous catheter. I would sequence that first. They talk a little bit about a pleural effusion, but when you have a congestive heart failure, you don't ever code pleural effusion with your congestive heart failure. It's considered a symptom of it. Case 3.3, this is an abdomen x-ray. This particular one, they had been there earlier today, and now this is for the 3 p.m. or 2 p.m. or 1 p.m., whatever it is. So you're going to need 2 modifiers on this. Your professional, obviously, and then a 76 modifier as well to get this paid. It's, again, for the placement of a catheter because of abdominal pain. So I would use both of those with your Z code for placement as your first one. 3.4a, this is a two-view chest x-ray. They have a clinical history of lung cancer. They suspect some pleural effusion. We can't code suspect. So the clinical reason why they're having this chest x-ray is that primary malignant neoplasm. Remember, no possibles, no probables, no nothing. 3.5, radiology of a femur. They have left leg pain. Make sure you have your left and your right, whichever is pertinent. Make sure your diagnosis code also is specific to the left or the right. This is a 2-view of a left femur. 6a, radiology of the knee, again left or right, because we have a mirror image, 2-view of the knee. This one actually gives a comminuted fracture. This is where if you have your cheats written in, like what we talked about, let me show you where mine are. From the ICD-9, I gave them to you for your 10s because the 10s, for whatever reason, aren't in there. This is a great cheat here. This is the beginning of the injury, dislocation, and fracture section. So here are my common terms for a closed fracture, and here are my common terms for an open fracture. And I've posted those in Blackboard. So if you don't know what a comminuted is, closed or open, that sheet will tell you it's a closed. Make sure you're getting your 7th digit correct. You could have an A, D, or S, and some others. A is for the initial. This is the first time they're being seen, so it would be the initial time. 3.7a, this is of the shoulder. Again, we kind of have a little bit of a convoluted scenario here. We're actually coding today 2 different shoulder x-rays from 15 days ago, and they're just now being coded. One was at 11:20 and another at 1. So we're going to have that 76 modifier again. This talks about right shoulder pain, but then in the impression they do give degenerative change. So I would code this to osteoarthritis of the right shoulder. Degenerative change means osteoarthritis, and I think you can crosswalk it that way too, and then just place it in your body part, which for this is your shoulder. 3.8, this is a KUB, kidneys, ureter, and bladder x-ray. Again, they're checking for the feed tube placement, so your Z code must be first. This was performed to check for the feeding tube placement exclusively. 3.9, this is a video swallow. No, it's submitting me. Video swallow. The clinical presentation is for dysphagia, and I do not see any definitive diagnosis that would take dysphagia off the table. So I would code this for dysphagia as a video swallow. CAT scans, CTs, however you want to call them. 10A, this is a CAT scan of the brain. Patient had presented with alteration of mental status. CT of the brain, so there's just one CPT code. Impression, there's possible and questionable and possible again. So I'm not sure that they know exactly what's happened to this patient. So I would code, to get this paid, I would code that alteration of mental status. Because we don't have a definitive diagnosis. 3.11, CAT scan of the sinuses. This one and another one is a little weird. This is a patient who happens to be intubated because of their congestive heart failure and their hypoxemia. So this is a CT of their sinuses. They must be complaining of drainage or have to be suctioned a lot or something like that. They do say that there's some abnormal density and filling of the paranasal sinuses, but they also say that sometimes it's not unusual to see this in a patient who's intubated. So that's really not a diagnosis. That may be a side effect of that intubation. So I would code this you'll need two CPT codes for the sinuses. You've got that 3D part of it. And then I would code it with congestive heart failure first, hypoxemia, and then the Z code for the dependent on intubation. 312A, sinuses, fever of unknown origin. Again, this patient is intubated. They do talk about some abnormal soft tissue stuff, but then they say the findings could be consistent with a sinusitis condition. However, the patient is also ventilated. So again, we're just not sure. So I would code this diagnosis-wise, fever of unknown origin, and then the Z code for the intubation. 313, this is a CAT scan or CT scan of the chest. The diagnosis is amyloidosis. And if you see, there's a whole lot of lung involvement with this amyloidosis, which isn't necessarily typical. You've got bilateral pleural effusions, you've got a volume loss or some scarring. So you're going to have to link your amyloidosis with lung involvement, and I'm going to show you how to do that. Get your CPT for your CAT scan. And then in the ICD-10, if we go to amyloidosis in the index, and this is one of those that we talked about on the Thursday night call, how if you kind of read, go back up and read, then you're probably going to, if you get in the habit of doing that, you're going to catch codes that you ordinarily wouldn't have caught. So let's see here. Let me get to amyloidosis. Okay, here we go. Here's our amyloidosis up here. And you can see it's with lung involvement, and you have your slanted bracket of J99. So your amyloidosis code is E85.4, and then you have to use that J99 as well. So let's go look at the E85 code. The E85, and what you're going to find here is it does not tell you to go pick up that other code. E85.4? Is it 4? Yeah. Organ limited amyloidosis. This x-ray that we're doing, excuse me, is exclusively the lungs. So this is a localized amyloidosis. It does not tell you to pick up the J99, but if we go to that slanted bracket code J99, right here, it has all kinds of flags by it telling us that it has that little half yellow circle, which tells us it's a manifestation code, which means it cannot ever be coded first. And then it tells us down here, code first the underlying condition, amyloidosis. So that's how we match them up. So maybe you want to put a note, the E85.4, put a note if there's lung involvement, code also J99. I don't know how you want to do that, but you will need 2 diagnosis codes for 13A in order to get everything that you need to get. 314, CAT scan abdomen and pelvis. Again, this is amyloidosis. If you look under amyloidosis, there is no linking to the abdominal involvement or anything like that. That's just the way it is. So your E85.9 would be your amyloidosis. You cannot do any pancreatitis because it's not confirmed. The atherosclerotic changes to the aorta, in the real world, you would probably pick this up. It's just an incidental finding, has no bearing on this case. But if you worked for a facility, they would want you to pick it up. From an outpatient physician-based coding standpoint, it has no bearing on getting this x-ray page, so we wouldn't necessarily have to pick it up. 15A, CAT scan of the chest, shortness of breath. Patients had a mastectomy, so that's going to be a status code for the absence of a breast. So you've got your post-surgical changes. You have your pleural effusions. And your post-surgical changes actually is that absence of breast. So you have 2 diagnosis codes here. 316, CAT scan of chest, abdomen, and pelvis. This one's a little bit more involved. We've got a lot of diagnoses going on here. The clinical symptoms, they've got a right lower lobe mass. They've got a AAA or an abdominal aortic aneurysm. They have increasing girth, which is probably ascites. That's a good description of ascites. And then they have fatigue. So the chest revealed some pleural effusion. We have some emphysema changes. We've got in the abdomen and pelvis, so you have 2 CPT codes. One is the chest and one's your abdomen and pelvis. You can't find all these body parts together. The abdomen and pelvis has ascites. There's your AAA. So I would code all of the clinical symptoms. Instead of increasing girth, I would do the ascites because you actually have it there. I would do the pleural effusions because you don't have a congestive heart failure on here, so you don't know exactly what's causing the pleural effusion. I would do the fatigue. I would do the emphysema. I think I would do all of them. And here's a good discussion on it. about how to convert some of what you're reading into a code or why you're not coding it. Very good little discussion on that. 317, this patient had a previous abdominal x-ray. They also did a 3D reconstruction, so you're going to have 2 CPT codes. And essentially what they've come out with, I would code the pleural effusions. Just making sure on this one. They already know about those pleural effusions. I would code an abnormal radiology, and I would code the pleural effusions if it were me. I think the answers just give you abnormal radiology. But I think we have very clear pleural effusion. We don't have congestive heart failure. So 318A, CAT scan, abdomen and pelvis. Boy, we've got a lot of these, don't we? But you guys are tired of it by now. This is the patient's had an elevated liver function test, and so now they're coming in for a CAT scan. So that's what I would use as my diagnosis. I don't think you can do too much with these hypodense lesions. I don't think there's anything conclusive here. One appears to be a cyst, but they're not telling you that it is. So I don't think there's too much you can do here. I would just default back to an abnormal liver function test. 319, CT kidney biopsy. You have 4 different CPT codes on this. So I want to kind of read through it so you see what I see. There's a CT guided kidney biopsy. The patient has severe chronic kidney and severe anemia. Etiology also, the patient has nephrotic syndrome. So those are your 3 diagnosis codes right there. CKD, anemia, and nephrotic syndrome. So now we have the patient prepped and draped. They're deadening, given some Versed and fentanyl. The inferior third of the right lower pole kidney was selected, and a biopsy was done, core biopsy was done, the inferior third of the right. Then they switch over and do the middle third of the right. So they have taken 2 separate biopsies of the kidney, 2 different areas on that right kidney. Then they change and do the inferior third of the left kidney. So we have 3 different CPT codes, 2 for the right, 1 for the left. The right is in 2 different places on that kidney. Then we have a post-procedural CAT scan, which kind of gives us some retroperitoneal hemorrhage. I'm not sure, that may just be from the needles going in. Not sure that has anything to do with the actual diagnosing. So you're going to have a 50200-50, that's for the right and left. And then you're going to have another 50200-76-RT for that second right one. Then you're going to have a needle placement, and then you've got your CT, follow-up study. Okay, so hopefully you can see where I was able to pull out the right and the left. And just forget all the other stuff. Peruse through it, but I've picked out what you need to focus on. CAT scan of the brain, 320. The clinical symptoms for this is a brain hemorrhage and primary malignant parietal lobe neoplasm. So make sure when you're finding the diagnosis for that brain cancer, you have it as specific as you can. Diagnostic ultrasound, 321A. This is for right lower quadrant pain, fever and chills. It ends up being normal. So when there's nothing in the impression, you have to default to the presenting symptoms or diagnoses that got them into X-ray to begin with. So you would do your ultrasound of the right lower quadrant, then you would do your abdominal pain, and you would do your fever. 22A, gallbladder ultrasound. The indication is for abdominal pain. It comes out being a normal gallbladder. So again, you have to default to that clinical presentation diagnosis, which most of the time is a symptom. 23A, ultrasound renal. This is for nephrotic syndrome. It also has post-void volume. Kidneys end up being okay, so your diagnosis code will default to that nephrotic syndrome. Ultrasound 324, ultrasound of the gallbladder. Abdominal pain in the right upper quadrant. This patient happens to be on a ventilator, so I would include that Z code. 25, ultrasound renal. Patient has chronic cholecystitis, so that's chronic inflammation of the gallbladder, chronic renal failure. They also are doing a bladder volume after voiding, so that's a urodynamic that you'll have to find in your urinary system. So you have two CPT codes. They end up finding multiple cysts. So you've got your CKD, your chronic cholecystitis, your cysts, and they found there's a large amount of ascites also. So none of those are necessarily symptoms of the other. Could be, but they're not linked that way. So we'll just code them out. Okay, so 326, ultrasound renal. This is because of a low urine output and increasing BUN in creatinine levels. Does state that there may be a small stone, but we don't code maybes, so we can't code anything other than the abnormal creatinine blood work and the low urine output. You'll have to think of your medical term for the low urine output. I'm going to let you guys Google that one and see if you can get it. Ultrasound retroperitoneal. This is a limited ultrasound for acute pyelonephritis. Very straightforward here. Very straightforward. Your ultrasound guidance here. Ultrasound right lower hemothorax marking. That's all they're doing is going in and marking where the doctor's going to go in and perform a thoracentesis. So your ICD-10 is going to be for that pleural effusion. They're marking the area, and then the doctor will go in later that day and actually drain the fluid off. Here's some wordy stuff regarding the radiation oncology. Just kind of sums up in a very concise manner the information from that area, worded in a different way. 329A, this is a radiation oncology consultation note. It is outpatient, so that tells you where to get your code from in the E&M section. Patient has a long-standing history of prostate cancer, and then they end up having a skin metastasis originating from the prostate cancer, and that's actually what's being treated now. So we have a secondary skin cancer from the primary prostate cancer. Patient's also wheelchair bound, so I would use the Z code for that. So make sure you have your secondary will be first, then your primary, then your wheelchair bound. 29B, this is the radiation oncology planning note. This is the simulation note. Here you have your field set up and you have your treatment device. So you'll have two different codes in this simulation. 29D is your progress notes, week 1 and week 2 for the radiation treatment that the physician is supervising. They do 5 fractions the first week. They do 10 fractions the second week. And I don't know if this is the end. I just know it's the second week. So don't do any fancy assuming that he's not having a third and fourth week. Just code what is here. Nuclear med, 320 or 330, diagnostic pulmonary function study, hypoxemia. This is a ventilation perfusion scan for hypoxemia. I wouldn't code the shortness of breath. I think the shortness of breath is a symptom of the hypoxemia. I almost messed you guys up. 31A, another ventilation perfusion lung scan. This is for right chest pain, right-sided chest pain. ICD-10 world, you will not be able to find a right side to chest pain. So don't kill yourself trying to find that. It's just chest pain. Interventional radiology. This is a hemodialysis catheter placement. Do not get this note confused with an AV fistula. That's a permanent. The AV fistulas usually go in the forearm and they take the vein and the artery and put them together. They are not creating a fistula. They are putting in a central venous access tunneled catheter. So go to that area in your cardiology section, cardiovascular section. And it gives you the tunneled, it gives you everything that you need. And then they also do have, you'll have to find it, it's gone from me. They have some guidance. So you've got to pick up the radiology code as well. Oh, I can't even find it now. The reason for the medical necessity for the placement of this catheter is that chronic kidney failure. 333, this is a gastroduodenostomy catheter placement. When they are placing the PEG tubes, you need to make a note. And let me get my, because it's just the way that it's coded. It's weird. It's just the way it is. If you look here, 49440 is the initial insertion of the gastro tube. That means it's only going into the stomach, gastro-stomach. And then it tells you here, if they're going further, if they're converting it from a gastro to a duodenostomy, which means it's down into the small intestines, you need to also code down here. So make yourself a note. When you see that a gastrostomy tube is going into the duodenostomy, going into the small intestines, it will take both codes to code that. Please make yourself some notes. If it's just a gastrostomy code and that's where they stop, then you're good to go and you just need the 440 code. The reason for this tube placement is nutritional deficiency. But you can see here, they start out under fluoroscopic guidance following administration of local. They do a gastropexy, so they kind of get the stomach still for a little bit. They dilate a gastroduodenostomy was placed. This doesn't give you great documentation that they went into the stomach first and then into the duodenum, but we see that they've done a gastroduodenostomy placed in the tip of the proximal duodenum. So that's enough to justify both of those codes. So just make yourself a note, because you'll see that quite a bit. 34, they're trying to do the same thing as they did in 33, but this particular patient, their stomach is severely, they've got a lot of pain. The stomach is dilated, so it's got a lot of extra gas in it. It's displacing the stomach to where they can't even tap into it. So for this one, I would code just the gastrostomy with a 53 modifier, saying that it was a discontinued procedure. 53, yeah, discontinued procedure. I doubted myself for a minute. And then you're going to have your abdominal pain, you're going to have your malnutrition or malnutrition. You're going to have the gas or the dilation issue, and then you're going to have your discontinued, your Z code for the discontinued due to this patient's anatomy. They just couldn't keep on going, the distension. 335, another gastroduodenostomy catheter placement, so you'll need both of your codes. This one is because of a stroke. Patient also has adult respiratory distress syndrome, and they're on a ventilator, so those are 2 additional codes that you'll need. Very normal for you to see that gastropexy. That's just a fixation of the stomach so it isn't moving around. They get in there and kind of tack it down so that they can make the incisions into it. Okay, and that is it. Again, here are your auditing cases to practice, and then we'll start with Path and Lab next.